Welcome to the second webinar hosted by TMTC and Ourmedic. My name is Dr. Vinita Manjure. I'm a GP with a specialist interest in women's health and endocrinology. Do we have the opening and housekeeping slide, Karan? If not, I can just talk through. Welcome to all those who are joining us this morning, and it promises to be quite an interesting webinar on joint replacements. We will get to know a lot more about osteoarthritis. I would like everyone to keep their cameras on, but their microphones muted, please. And that gives the best experience to the people who are interested in knowing more about osteoarthritis. So joint pain, whether it be from arthritis, injury, or age-related degeneration, can affect people's quality of life. Recent statistical data from UK reveals that there are almost 200,000 joint replacements carried out in the UK. And this number is expected to grow as the population continues to age. And along with that, the incidence of osteoarthritis is also likely to increase. Hence, the waiting list will continue to grow, and the waiting times for the patients will continue to get longer and longer. Advances in technology, surgical techniques, and international collaboration are transforming patient care and outcomes. So what we have today, this morning, is an esteemed panel of leading experts, both from the UK and from India, and this will help us unravel the journey from diagnosis through to recovery. And I'm very pleased to invite my panel, Mr. Sanjiv Manjure, who's a consultant orthopedic surgeon specializing in joint replacements and revision surgery and sports injuries of the knee. He's also the founder of Ourmedic.com, and he's from the UK. Practices at Luton and Dunstable and the Bedfordshire hospitals in the UK. I am also pleased to invite Dr. Naveen Talwar, who is the Director of Orthopaedics, Joint Replacement, Spine and Sports Injury of MASSH Super Specialty Hospital, New Delhi, India. Good morning, Dr. Talwar. And equally, I'm pleased to introduce to you Mr. Georgios Tsiknas, who is a specialist vestibular and MSK physiotherapist from the House of Health and the founder of Your Caring Physios UK. So my first question, which I will open up to the panel, would be to Sanjiv, and that is, what are the most common reasons for people in the UK needing joint replacements?
Hello, good morning, everybody. Thank you very much, Vinita, for the introduction. As we know, the most commonest cause of joint replacement in the UK and in my practice is osteoarthritis. Almost 90% of the patients whom I see have this condition. There are certain other conditions like rheumatoid arthritis, gout, and other inflammatory arthropathies, as we call them, where there is inflammation of the joints leading to arthritis. One of the other common conditions which I see in my practice and across UK is post-traumatic, in the sense that those patients who have had fractures in the past or have had knee injuries, be it sports injuries or any other knee injuries like meniscal tears, and who have had keyhole surgeries on their knees. These are the patients likely to develop arthritis, and these are the patients who come to the clinics and present themselves with knee pain, swelling, etc.
Thank you for that. My next question again is to you, Sanjiv, and that is, with your practice in the UK and the waiting list now being a challenge, how do patients typically navigate arthritis care in the UK?
Yeah, so that is a very interesting question. And in post COVID or during COVID and post COVID, the waiting lists have gone up significantly. We are still catching up, and according to the British Orthopaedic Association, it's going to take almost 8 to 10 years for us to catch up from the lag and the delays we had because of COVID. We have what is called as an MSK service within the UK, which is what is musculoskeletal service, because not all patients with arthritis require joint replacements. They could be treated with various other non-operative or minor operative measures, and these are the measures which are done by the MSK clinicians before they come for joint replacement. So, in the initial stages of arthritis, all these treatments could be undertaken.
Wonderful. And I'm sure these answers are going to invoke a lot of questions. So I would ask people to put their questions in the chat box, which I will monitor, and we will try and take as many questions as possible at the end of the session, if that's okay. Right. So again, what are the key innovations and advancements in joint replacements that people in the UK should be aware of, Sanjiv?
Absolutely. So there have been many changes and advances as well as innovations in joint replacement surgery. I've been practicing in the UK for the last 25 years as a consultant, and I've seen major changes. So if we take changes in a different subgroups, if you look at technology, a lot of technological advances have we have taken those technological advances within orthopedics. For instance, navigation, computer navigation has come in. Other things like robotic surgery or robotic assisted surgery. We also seen joint replacements using patient specific bespoke implants. All this has made a huge difference in terms of improving the alignment and overall outcomes for joint replacement. What it has done is taken out the human error which was there in when we used to do the replacements manually. Other key changes are in terms of the incision lens, that is making the surgery in less time, also less blood loss, not using tourniquet. So all that has made recovery pretty quick as compared to what it was 10 years ago. There have also been changes or advances in metals and the plastics which we use for joint replacement. That has made the wear of those implants less, and therefore longevity of joint replacement has improved.
Excellent.
Thank you.
Which then automatically leads me to the next question. And with all these minimally invasive techniques that are currently employed by clever guys like yourselves, what are the different factors that change the overall outcomes in patients? And I would ask both Sanjiv and Dr. Talwar to take this question.
Well, I've talked enough. If Dr. Talwar wants to say
Yes,
a few
please.
words
Thank
on that.
you.
Thanks.
You are muted, Dr. Talwar. You are muted. You may wish to unmute yourself. Sorry about this.
Shall I?
Yes, why don't you
Yeah.
take that question?
So what you want to know is the outcomes, how the outcomes have improved because of all these advances, right?
That's correct.
Yeah. So In the UK, what happens is each and every joint replacement, right from 2001, is entered into a national database, which is called a National Joint Registry. And each and every patient is followed up within that National Joint Registry. So if a surgeon has done, say, a joint replacement in 2002, today in 2025, especially if the patient is alive, you'll still know the outcome of that joint replacement, whether the joint replacement is surviving or whether it has had a revision surgery. And looking at the outcomes from the National Joint Registry, it has shown that less than 5% of the patients have their knees revised at 13 years. So, to translate that, 95% of the patients with knee replacements survive at 13 years. If you extrapolate that to 20 years, almost 90% survive the joint replacement, and at 25 years, the survival rate is 82%. So this previously we used to quote 10 to 15% average survival rate, 10 to 15 years of average survival rate. But now with all these significant advances, the survival rate has gone up significantly, and that is a great benefit to the patients, and also in terms of revision surgeries, which is a costly affair, as you know.
Thank
Am I
you. Thank you,
audible
Sanjiv.
now, Vinita?
Yes, you are audible now. And maybe, Dr. Talwar, you want to bring to us your India experience.
Yeah, so I would say that India has kept up with the times, and as Sanjeev has made my job easier, he's answered my question well. Uh, with the implants being used, the metal which has gone over a big change, and the anesthesia, so there's less bleeding, the size of the incision, which is like we do for a minimally invasive surgery, and also the rehab post-operatively. So everything seems to have increased the survival rate, as he said rightly, Dr. Sanjeev. And secondly, the back to activity level has come back very fast. So, there have been cases where we have, the patient has been able to get up the same evening after the surgery and gone to the washroom the same evening. Next day, anyway, is a usual rehab procedure to make them stand, sit on the chair, use the WC, etc., with some precautions. So it's gone a big change. I've myself been in practice close to 30 years now. What we had initially and now it has changed the overall success of a total knee replacement or a total joint replacement.
Thank you very much. So we've heard about all these clever operative techniques, but a lot of people, Georgios, are very keen to know whether there are any other treatment modalities that can be tried for arthritic pain without having to resort to surgery. And what in your experience would be a good way forward?
Of course. So when we follow like a conservative treatment, we're looking as physios to first of all education of the patients to understand and how they can manage, and also we give advice. For example, weight management. If they lose weight, then this can help with the pain. Another important thing is like lifestyle changes. We try to encourage people to become a bit more active if they are not. Exercises. So we try to do like low impact exercise depending on the levels of pain. They can do strengthening exercises to strengthen the muscles, hydrotherapy, which is a low impact type of exercise. We suggest ice of heat, where they can manage again the pain. Other things is like cycling that they can do, looking for balance exercises. And we try to from my perspective as a physio, also I'm trying to explain to them that the imaging doesn't explain the pain, which is very important to explain this to the patient. So if they have a good understanding, good education, and a form of exercise, I think they can have great results.
Excellent. So, as a physiotherapist, you are probably one of the first contacts patients have when they start to get arthritic pain. So, you
Yes.
obviously follow their journey in the initial years of this condition. At what point do you then suggest to your patients that they would benefit from joint replacement?
So the idea is that as long as they follow all these and the pain, so they try the pain management, which is prescribed by the GPs. They have tried physio, they have tried things, they have lost weight, but it still affects their sleep, the quality of life, which is daily activities, work, hobbies, and then eventually this start affecting their mental health. Then I suggest to try and discuss this with an orthopedic surgeon to explore this as an option. And another thing is the injections. So they try the conservative management, they try the advice, they try all these things, try injections. When things don't work, then the next thing is a replacement.
Okay. And a lot of people believe that, physiotherapy only comes into picture or rehabilitation only comes into the picture in the post-operative period.
Mhm.
What are your thoughts on, being in the best health prior to the surgery? And what role does physiotherapy have to play in that?
Definitely. It's very important to prepare the patients, because what we can do is we can educate them, we can discuss the post-op rehab, we can work on strengthening, because strength also helps with the pain and helps them post-op, they know what to expect in terms of the rehab. We practice stairs with them, we practice walking with crutches. So I think it's a great benefit for them as a preparation. They know to expect, and for a good strength of the muscle group before the joint replacements.
Thank you. Thank you so much. That was extremely useful. And it kind of paves my way to ask the next question to Dr. Talwar. What we notice is because of the long waiting times on the NHS, a lot of people are now getting very frustrated and thinking about, going to other countries in order to get their joints replaced, purely because 8 to 10 years just to, get over the backlog because of the pandemic seems to be pretty long. So therefore, Dr. Talwar, how do joint replacements in India compare in terms of surgical expertise, technology, and post-operative outcomes?
We have very good results in joint replacement surgeries. We have been doing it for a very long time. So let me first start with the surgeon's expertise. See, majority of our doctors were trained under the NHS years back, which is including me myself way back in 1994. So the people know the practices which are followed abroad, and more or less it's the same as we do in India. So surgeons are highly experienced, keeping in mind their training and keeping in mind the volumes of surgeries we handle in India, because the numbers are huge, humongous numbers. Now we have, with that, I'll come to the next step, which is the anesthesia. So the anesthesia bit has also evolved. We have anesthetists who are only dealing in orthopedic cases, and so something called hypotensive anesthesias, something called you have under combined spinal and epidural blocks. So we have trained anesthetists to help us out during and even post-operative for post-operative pain, using the combined spinal and epidural anesthesia to be able to relieve pain post-operatively. Now, coming to the tech part of it, we have remained absolutely abreast with all the technology which was being introduced in the West. and it has, for whatever reason, come to us immediately whenever it was introduced in the West. So we have been doing this assisted navigation, robotic assisted surgeries, minimally invasive surgeries for joint replacements from as and when they were introduced in the West. So I feel the results are absolutely same as we see in the West. The infection rates were compared, and we still fall in the same category that it's 0.5 to 1.5% of the patients. And rehab, which is post-operative, has also advanced in a very huge manner. So we have specialized rehab personnel who are dealing with joint replacements, particularly, and following protocols which we see in the West. So I don't see any difference from results, what you would be seeing under NHS and with us. Expertise of the surgeon does matter a lot, but I feel it is all combined. These are five or six verticals which are combined to give a very good result.
Excellent. What was extremely reassuring for me to hear was that the infection control rates are very much comparable to the rest of the world. And I think that will give people a lot of confidence. So, on that
Absolutely.
note, yeah, uh, we talk about costs of all these surgeries. So, in terms of cost, how does India compare to the rest of the world?
Uh, the
Affordability, let's call it affordability rather than cost.
okay, let me say, people here pay more out of pocket than people have a state insurance. Very few people are insured, and there are some government schemes which do benefit from them, but it's mainly out of wallet, and the cost here is significantly lower than what a person would spend in the West. Uh, Starting from the cost of the implant and going up to the stay in the hospital and even stay in a center like what TMTC has created. I think it's a great idea that you move on to a facility after 3 to 4 days in the hospital, which is purely like home. So you have your a living room, you have your bedroom, and you have around the clock physiotherapy personnel to be able to do or work on your knees or hips 2 to 3 times a day. So all combined, and coming back to your question, it's significantly lower than we see in the West.
Okay. No, thank you for that. And then the typical question would be, what would my journey look like? So, if I was a patient suffering from osteoarthritis and I was wanting to make these very informed choices, what would my journey look like, before surgery, during surgery, and after surgery for that matter?
Okay, so I'll call it a navigation route which the patient would take. So let me start first from UK itself. So it'll mean the person going to the GP and the GP getting the X-rays done, etc. Uh, Referring it to the orthopedic surgeon in the vicinity as the system goes in the NHS. The orthopedic surgeon evaluates it both clinically and diagnostically, which would mean usually just radiology. And if he or she finds that the patient needs a total knee replacement, obviously a letter goes back to the GP. And that's where, we come in. The the personnel or the doctor sitting here would be able to access the records of the patient there and manage to speak both to the GP and the orthopedic surgeon. And finally, we have thought of a counseling session. I'm sure the GP and the orthopedic surgeon under the NHS or with the TMTC people would have counseled the patient about the surgery. But we look at a video call or a Zoom call with the patient, and we reaffirm again to the patient what this whole thing, joint replacement, is about, and reaffirm the faith that your records have been, after due confidentiality clauses, they have been, shared with us, and you seem to be fit to travel to India and get the surgery done. There are few things which our own the patient's GP might get a few tests done besides the X-rays, and those are basically tests to see that the patient is fit for anesthesia. I don't see it right that the patient travels all the way to India and then at the last moment we say that the patient is not fit for anesthesia. So we did deliberate in the last webinar that there will be few very, very simple mandatory tests which the patient will go through under TMTC with some lab which they're going to affiliate to. And once that's cleared, the patient is fit to travel and the patient is fit for anesthesia, the patient will be referred to the orthopedic surgeon in India under TMTC, and TMTC would then be the hospital concierge for the patient to be able to travel to India, get received at the Indian airport, and taken to either the guest house or the facility which has been set up or brought to the hospital, probably, I think, after resting, after a long journey, after 2 days, to come to the hospital. At the hospital, you get a orthopedic consult from the treating orthopedic surgeon. He or she would then refer it to the local anesthetist in the hospital, get the necessary tests, the blood work done, which is needed for the surgery, and then the big day comes and the patient gets operated at the hospital. It's a state of the art facility. It's a 50-bedded joint replacement hospital with the in house ICU, the in house cardiologist department, and in house all specialities needed for taking the patient up for surgery. Once the patient has been operated and gets shifted to the room, we have other players coming inside into the arena, which would mean the rehab team. So the rehab team and the pain clinic team. Now, when I say pain clinic team, I mean is the anesthetist who would be looking at pain control post surgery. They'll be visiting the patient twice a day in the room itself to top up the epidural block so that we don't have to give more medication orally or intravenously. We could manage it just through the epidural cannula. Second team to come into play would be the rehab team, at least 2 to 3 sessions a day so that we can have the patient up and about ASAP. After this 3 to 4 days journey in the hospital, the patient is shifted to the TMTC facility, which I was talking about initially, where we have, I visited myself multiple times. It's a wonderful facility, which is actually like being at home with an in house physiotherapy department, a full floor which is devoted to it, with all the equipment and in-house physiotherapists to be able to work on the knee or the hip or any kind of joint replacement for the next few days till the patient is with us. And during this journey, a very important thing which I want everyone to understand and keep it in their mind is that a very proper DVT prophylaxis is done from the time the patient enters the OT and will be continued till the time the patient reaches back home in the UK. Now, this is we even include injectables which might be given the moment you take your ride back home by air, and then get shifted to the oral medication for another 2 weeks when you are back home in the UK. So typically, this is what the journey looks like, and I'm happy to answer anything if I've missed. But typically, it's this is the journey which we feel will get the patient back home healthy and pain free.
Okay. That's extremely, again, the word reassuring keeps coming back to mind. The journey in India was very clear. What I would like to clarify is that the TMTC is offering a package where they get their initial GP and specialist consultations privately through TMTC and not their own NHS GP. Am I correct in my understanding?
Yeah, these are you asking me? Yeah, these are doctors the orthopedic surgeons who will be, and the GPs who are going to be on under TMTC,
Yeah,
so that we have a direct link up with them and we don't have to go through the usual
NHS
long
GP.
route of being able
Yeah,
to get their them to listen to us and vice versa.
correct. That's all I needed to confirm so that, whoever is listening in is very clear about how their journey in UK looks. The India journey was very, very clear. So, no, thank you so much.
Okay.
Uh, So, Georgios, post surgical protocols, Dr. Talwar has given us a little idea of how it happens in India. Is that very comparable to what we do in the UK?
So yeah, so the journey in the UK actually is that as an inpatient, they're trying to get someone as soon as possible home actually. So they're trying within a day or the second day to get them home. And it's the idea is of the early mobilization, encouragement of them to exactly try to sit to stand, walk a bit, starting with a frame, progress to crutches, and eventually to stick, and it's no walking aids at all. Yes, and that involves a lot of physio, start moving, for example, the knees um, early so we can get the 90 degrees that we need, especially from the post-op, if we can get it. There is yes, another different technique, passive movements, CPN, which is machine, and plus the exercises. And definitely we're guided by orthopedic surgeons, and of course from the pain as well, because it depends from the patient and yeah, and of course,
Okay,
and
so
then we
it's
start
all
the
tailored
journey.
to the patient requirements.
Yes.
Sanjiv, having heard from Dr. Talwar, uh, what do you think about the thromboprophylaxis that they're planning to offer? And my question also would be, what would happen? Say, for example, complications can happen post-operatively, if not immediately in the few weeks following the surgery. I know the chances are very rare, but should some complication occur, how would this be managed in the UK?
Absolutely.
So it's like a two-in-one question.
Yeah. So, no, many thanks, Dr. Talwar, for explaining this journey. I think post-operatively, because the patient is traveling, like within 4 weeks of the surgery, to give thromboprophylaxis for a longer time, slightly longer time than recommended, is much better. We in the UK give thromboprophylaxis for 2 weeks following joint replacements, be it aspirin or other agents. But if the patient is traveling, then it probably makes sense to extend that till the time the patient is fully mobile and back within the UK. Second part of your question regarding complications, as you know, complications are a part of surgery, and it's in some patients they unfortunately they do happen. As I understand, TMTC has got an insurance package till about an year, so the early complications can be dealt with under that package. And if God forbid, if the complications arise, especially things like infection or any clots in the legs or the lung, those could be dealt with on the NHS as well as an emergency. But if these are these complications can be treated in the private sector via the insurance package, that is also possible.
Excellent. So I do have questions that were already sent to us prior to, but I think the question I want to take first is from Phil Bailey, who asks, how fast can this happen? And have we got a cost? So the cost, if we keep aside the cost, how fast can this happen? Dr. Talwar, would you like to take this?
Honestly, if the patient gets cleared, as I said in my navigating journey, uh, that if the patient gets cleared by the local orthopedic surgeon with whatever blood work and the x-rays, and he's fit or she is fit to travel, this could we are all ready with the facility, and
Perfect.
and we could do it ASAP.
Perfect. So, Mr. Bailey, somebody from the travel medical company will contact you at the end of this consultation so that they are able to then get you the required appointments and discuss the cost and all that. Would that be all right? You may unmute yourself, Mr. Bailey, if you wish to. Okay, fantastic. Somebody will get in touch with you at the end of this seminar. We have also had questions posted to us prior to, and maybe we could take it at this point. I'm just conscious of time. We've got another 15 to 17 minutes to go. So let me go with the first question, which goes as such. These were posted to us prior to the webinar. So it says, I'm 72 years old and both my knees are arthritic. Can I have my both my knees replaced at the same time?
Am I audible?
Yes, you are. Yes, you are.
So, could you just repeat the question? I just had a problem with the audio. Could you
No
repeat the
problem.
question, please?
I will. I will. So the question is, I'm 72 years old. I have both my knees are arthritic. Would it be possible to get both my knees replaced at the same time?
Now, I must give you my experience. So, I'm speaking from India. My personal experience has been that we operate both knees much more than we operate a single knee. And this has the reason because people here, once you do a single knee, then you wait for another 3 to 6 months for the other side. So the cost goes up for our local patients. And they also want a procedure once, medication once, and everything related to rehab once. So we've had a very good, successful journey with replacement of both knees at one time, and we counsel the patient accordingly. It's a very personal choice from the patient side, but we are, if the pre anesthetic checkup clears the patient for surgery and there are minimal comorbidities, we are more than happy doing both knees at one time also.
Excellent. Okay, so the next question was, if I decide to get my two knees replaced at different times, what is a safe interval? Sanjiv, would you like to take this question?
Yeah, I just want to go back onto that bilateral knee things, if I may, please. So in the UK, this was a big trend of doing bilateral knees at the same time, and 10 to 15 years back. But eventually, it has sort of fizzled out. There are still, in my practice, I still at times do bilateral knees at the same sitting, but most of our patients have slightly higher comorbidities. And with these patients, it is better to do it one at a time. Of course, if there are patients who have minimal comorbidities or no comorbidities, they fare really well. If you look at evidence in the medical literature, it has clearly shown that patients who have comorbidities have a higher risk of complications like infection, clots in the legs and the lungs, etc. And therefore, lot of surgeons within the UK have gone away from it. But that doesn't mean that it's not a one size fits all thing. Patients who have minimal comorbidities or no comorbidities and would like to get bilateral done, I think it is still a great option.
Excellent. And
Um,
if somebody doesn't choose to get them, the two done at the same sitting, what is the recommended time, interval
so
between the two?
Yeah. So the ideal time is around 3 to 6 months. The reason being, by that time, the patient recovers from the first surgery, the mobility has improved, and is enjoying the benefit of the replacement surgery, and then he or she can go for the second one. There are patients who would like to wait longer because their recovery is a bit slow. As we know, each patient's recovery is a very individual thing and doesn't go according to the to plan. But there are some patients who recover very quickly, and these are the patients who would want that surgery earlier than 6 months. But on an average, I would say 3 to 6 months is a very good interval.
Okay.
Thank
Can
Thank
I
you
you.
so
just
much. That
come in
was
for a
very useful.
second?
Yes, Dr. Talwar.
Just to add to your question and the answer Sanjeev gave, that the selection criteria is highly stringent for cases who want to go in for both
For
knees.
bilateral.
So we just rest assured, people who are listening to us, that it's for a bilateral knee. We'll totally see to it that you are cleared medically so well that we don't see the complications any different from a unilateral knee.
Perfect. So this is another very interesting question because Dr. Talwar, you talked about how the rates in India are very competitive and much lower than in the West. So the question therefore is, what knee implant brands and technologies are you using in India? Are they same, similar to those in the UK? And why is the cost of implant so less?
We are using exactly what they use in the UK or the US. There are some personal surgeon preferences for reasons of results and what you have grown up with. So you tend to continue using something which works. So I also feel that things we were brought up on and adding to them some innovations with time. So one is been using implants from Switzerland, from UK itself. So we commonly use Stryker implants. We commonly use Smith and Nephew implants. We even use implants made from Germany, which is the Asculap. And so these are the commonest implants we are using, and including Johnson and Johnson, which does the DPU or the knees by Johnson and Johnson. These are all very well-known brands abroad.
Brands.
But
Yeah,
as I said, that these are it's a very personal preference of what results have been are the best for the surgeon, and we are more than happy giving the best results to the patient. So I feel now coming to the cost part of it, it's probably the cost here is much less because of implants being imported by India from the West. They come with much less percentage of taxes, and the cost for a country like India and Southeast Asia anyway is much lower for the same implant for which people pay 2 to 3 times in the West, including UK.
excellent. That was very interesting. Sanjeev, do you use similar implants?
Yeah, so the names mentioned by Dr. Talwar are similar ones being used in UK, and also for patients who want to know about the implants, and if they know in advance what implants they are going to use, they can look on the National Joint Registry or any other registries across the world how that particular implant is faring in the hands of different surgeons. So there will be an average, and hence the patient can then decide as well. And as Dr. Talwar said, in the surgeon's hand, that implant is probably worked the best. So yes, I think the decision will be made, but for the information sake, the patient can look on the National Joint Registry as to how that particular implant is doing.
Okay. And then there are questions I'm getting on emails now. Um, Sorry to go a little topsy-turvy because we've already sort of come to the operative intervention. But there is a question here, and perhaps Georgios, you want to take this one? I hear that there are injections I can take instead of going for a knee replacement. Do these work in the long run?
Good question. The answer is it depends on the severity and depends on injection, who injects, if there is ultrasound guided. But in the long run, no, eventually they will need an operation.
Knee, knee
Mm,
replacement. Yeah.
mm.
I hope that answers the question. And then there is another one, perhaps both
Yes.
between Sanjiv and Dr. Talwar, you can take this. How soon can I fly back after the knee surgery in India? And how long would I have to stay in the hospital?
So here, typically for a local patient, I'll start with that. A local patient would get in 1 day before the surgery to the hospital. They get all their blood works, etc., done, which I'm repeating now, including the pre-anesthetic checkup, any X-rays needed at that particular time. So this is what is the day before. Next is the day of surgery, and we send the patient back on the fourth day. So we have packages where the stay for the patient is usually between 3 and 4 days at the hospital. In this particular project by TMTC, it will be the same. It will be a day before, you'll be there in the hospital. Day two is the day of surgery, and after 48 hours to 72 hours, you'll be shifted to the TMTC facility for recouping after the surgery. Coming to the travel part, we have been dealing with medical tourism from the Middle East and from the CIS countries in the past maybe 20 years now. And typically, our patients leave India from the 10th to the 14th day. So that is the rough average when you are fit to travel with a proper thromboprophylaxis after 10 days of the surgery or close to 14 days of the surgery. So that's typically the time one can go back.
Okay, so we are trying to keep it as safe as we possibly can.
Absolutely.
Sanjiv, any thoughts there?
Yeah, no, I think Dr. Talwar has answered this beautifully. The issue is that literature, there's no fixed term or fixed time when you can travel according to the medical literature. So ideally, it's a slightly longer time, but then after 2 weeks, the risks of getting clots in the leg and the lung goes down significantly. And especially if you're covering with medication, that even goes down. Also, if the patient from the physiotherapist, if they're guided as to what they should do while they are traveling in the plane, when it's a longer journey, that would help reduce the risks. So I think all those things, if they are put in place, that would help and make sure it would make sure that the risks are minimal.
Excellent. So I think we have covered most of the questions.
Vandita, sorry, there is one question which Vandita sent on the group, and
Okay.
I think I will take that because it's more relevant to the UK practice. And somebody has asked that I need hip and knee replacement. I have lost 5 stone. My BMI is 44. NHS won't do my surgery, but private hospital will do it. Why? Um, I think the most hospitals now have a cutoff of 40 BMI, not because they don't want to do the surgery, but because there is enough evidence in literature to show that patients who are operated patients who are over the BMI of 40 have a higher risk of complications, um, complications plus risk to life. And therefore, most of the NHS trust and clinicians have decided that they would not operate on patients over 40. And this is true especially for knee replacement surgery. There is clear evidence there. For the hip replacement, you can still, there is a leeway and you can go slightly higher. Um, as regards why the patient has been told that he's okay to have the operation privately, I cannot say. But as far as my practice is concerned, I follow the same protocol and same guidelines as I do in the NHS. So if I don't do any patients over the BMI of 40, I would follow the same on the private sector.
Okay. I hope that answers the question. And very well done to whoever lost 5 stone. That is absolutely a brilliant achievement. Going on to the next question. For how long do I have to wait having physiotherapy until I start driving? Perhaps, Georgios, you want to take this?
Yes, definitely. So here in the UK, actually, what we're looking from a physio point of view, we're looking to improve the range of movement, strength, balance, progress with walking. And then when they have a 6-week review, they have to wait at least 6 weeks. When they see the consultant, then they have the okay, and then they can start drive. And the idea is, as long as they don't suffer from pain, they have the range, and they can do 3 immediate stops, then they can start driving.
Okay. Helen, does that answer the question?
Second, sorry?
No, this was a question from a lady called Helen Panastopolo.
Mm-hmm.
So I was just sort of confirming that her question had been answered.
Yes.
Brilliant. I think we don't have any more questions. We are 3 minutes shy of midday. So yeah, this was a fantastic webinar, and I hope we have been able to give people who have been listening into our webinar a good idea of what arthritis is, how knee replacement, well, how physiotherapy, minimally invasive therapies, and eventually joint replacements work, and what is required to bring the best outcomes with the least complications. Thank you to the panel today. Thank you, Georgios, Dr. Talwar,
Thank you.
Sanjiv, and thank you to all the back office guys for supporting this webinar and ensuring that the IT ran very smoothly. Any questions and anybody who would like to know more about the product, do contact the travel medical company. Vandita has already put all the details in the chat box. So please do get in touch if you would like. And on that note, thank you very much.
Thank you so much. Thanks a lot.
Thank you. Vandita, should we stay back?
Let's end this meeting.
Thank you. Thank you very much.
Thank you so much. Thanks, Sanjeev.
Thanks.
Thank you, everyone. Thank you.
See you guys. Yeah. करेगी आप बात कर लो